I'm Josh Marx, a healthcare transformation specialist with the New Jersey Academy of Family Physicians. I'm excited to be presenting with JFK Family Medicine today. They're a unique practice that has fully embraced practice transformation over the last 7 or 8 years, working with the New Jersey Academy of Family Physicians prior to me starting as well. They really have not been afraid to try new things and keep moving forwards as they kind of gear up for high value or value-based care. So our learning objectives for today are participants should be able to determine how PCMH applies to their practices' overall value-based care transformation goals. Participants should be able to better understand how to align specific PCMH standards with their practice's immediate and long-term workflow improvement plan. And participants should be able to identify how to incorporate PCMH standards into existing processes in order to improve them and to sustain that improvement or develop new processes that are valuable and sustainable. I think the most important thing to note is that the NCQA PCMH model has changed several times, probably in the last 10 or so years. And this practice has really kept moving forwards with each iteration and trying to find success as a PCMH, and now as they work in CPC Plus, an advanced alternative payment model, as well as their MSSP APM, ACO. So I put this slide up here. It comes directly from NCQA for a couple of reasons. I think a lot of this is known by most folks, that the majority of the costs in healthcare are generated by less than a majority of the folks in the population. And I put this up here for a couple of reasons. Two, because we have the arrow moving towards the upper left. Where are we trying to go with high value care in the future? But also for another reason, the two areas of PCMH that we're going to be discussing today really look at targeting the patients in this high cost group, the early symptom, active disease, and maybe even some of that high risk or rising risk population. So again, another slide from NCQA directly. What are some of the drivers of high cost? So there are several on the page here. The three that we'll mostly focus on in the course of our talk are, we have a reactive focus on symptoms rather than proactive health management, fragmentation, poorly coordinated care, and no champion to help the patient navigate that system. We'll be diving pretty deep into that today, as well as discussing the practice's challenges with limited transparency and information sharing. Simply, the physicians lack the complete picture necessary to manage their patients' health. And I think we see that starting to improve now with data sharing, but that's something that wasn't in the previous landscape. So I put this slide up here not to stir controversy. I think some folks may have read literature that says that the PCMH does not lower cost or it's not worth the return on investment. I've cited the studies that NCQA has mentioned here. I think the most important thing to note is that some of the interventions that we'll discuss today, mostly related to care coordination, transitional care management, and care management as well, if done correctly, with the correct intent, can move the needle on some of these measures. So, take these numbers with a grain of salt. The links to the citations are below, but really what I want you to understand is that we need to look at these interventions and monitor if they're effective in our practice and make changes over time to understand if they are working in our practice, and if they are not, try new things, which is what Dr. Metz and Dr. Winter are going to discuss with you now as they talk about their success as a PCMH.
I'm going to give some context to our practice as you hear the transformation that we've gone through. We're in Edison, New Jersey, where the star is. And we are a teaching practice, so we're integrated faculty practicing with our residents. We have 24 residents total, and a total of 11 faculty that are practicing within the context of the same office. We are on Centricity, our EMR, an older version of Centricity, and have been using it since 2005, so we have many years of experience in using it. And we are connected to the Central New Jersey HIE for information and exchange. In addition, we do have a behavioral scientist in our practice, a PsyD, so we have integrated behavioral health within it, and then have 2 nurse practitioners along with the physicians and the residents. And we have a mix of nurses, RNs, LPNs, and MAs. Probably some more nurses than would usually be in RNs than would usually have in a practice because of our hospital-based system. And our Health Start program is a prenatal program which has its own dedicated nutritionist, social worker, and nurse dedicated towards our prenatal population. So we are caring for the full spectrum of age, all the way from prenatal care, newborns and children, to the elderly, and 19 non-clinical staff support. More importantly, we have a little over 31,000 visits last year, with about 10,000 active patients in the practice. We are a diverse population in the Edison area, and our practice reflects pretty much the diversity of our community. And what is a little different in our patient base compared to other practices is the large number of Medicaid and uninsured patients that we take care of, and a smaller percentage, 10% about, in Medicare. With uniquely within our CPC Plus practice, it's over 53% are dually eligible, both Medicare and Medicaid. So we have a larger Medicaid uninsured population than probably a private practice would have. We started our journey working towards patient-centered medical home, motivated primarily for the improved patient care that it offers in terms of continuity and comprehensiveness. It also became a major tenet within the specialty of family medicine to focus on patient-centered medical home, and became an imperative for us educationally for our residents in training them for the future to be practicing in an environment of a patient-centered medical home as the basic foundation for the educational program of the residency. And it enhanced both our resident recruitment. It was not really for the financial component because it's primarily a Medicaid with a large uninsured population. The third-party payers were not really incentivizing patient-centered medical home transformation in any way. And we started in 2011, so we've been doing this for about 7 years, and we actually started partnering with the New Jersey Academy of Family Physicians that assisted us in the process of the patient-centered medical home and the NCQA certification. And along the way, in 2011, we were our first recognition by NCQA as a patient-centered medical home. Around 2012-13, we received and were part of a practice transformation grant through the HQSI and Robert Wood Johnson, which assisted us a little further along the lines, primarily focusing on our workforce re-education, and then have recertified 2 subsequent times as a patient-centered medical home in 2014 and most recently in 2017. And we are a participant in JFK's ACO, and we are a CPC Plus Track 1 practice. The portions of the transformation we're going to focus on, that Dr. Metz will focus on, are really care coordination and risk stratification and the challenges that we've faced in implementing both of those 2 key characteristics of a patient-centered medical home.
All right, thank you. So, starting our journey, we in 2011 we did our first certification for PCMH using the 2008 PCMH standards, and they're up there. I know you can't read them, but they're up there as a reminder for me to say that there really wasn't a systematic process that PCMH expected. There was no process or protocol that had to be in place. We just had to show that we could do it. And we dutifully won said, okay, we found these, I think it was usually 3 examples of somebody that had been in the hospital, had been discharged, had a follow-up appointment, that kind of thing. So it wasn't particularly robust kind of thing or practice-wide. So what we did, what helped us along is as a residency program, we admitted our own patients to our own hospital service. We didn't have a hospitalist service that we employed or any middleman, middlewoman, other providers managing our hospital patients. So that helped us that we at least knew who our patients were when they were in the hospital, and somebody in the practice knew what was going on at the time. So we could do it, you know, we could follow up with our patients if we thought about it hard enough. What didn't work is we didn't keep any kind of registry or log. So if we weren't really tracking if Mary Smith was admitted 4 times in the past year compared to other patients that might not have, or were only admitted, say, 1 time. We got nothing from other hospitals. We had no idea if our patients were going to other medical centers or were admitted there for whatever reason. We really had nothing set up as far as an episodic case management system to systematically identify these patients and make sure that we were following up with them. So we really had no systematic process to close the loop from the hospital back to the practice, that transition back to the office and back to home. What PCMH did, though, was it got us thinking about these processes and how we could do better. In 2014, when we submitted a second time using the 2011 standards, one word that shows up in these, in the PCMH standards is process. And that's kind of a key word, is that the PCMH became, and those of you that have done PCMH, PCMH is a lot about process. And what's your process for? You know, show us your process and procedure for X, Y, or Z. So we had to come up with a more process, and we had to be more systematic with identifying our patients that were receiving care at a hospital or an emergency room. So we started collecting discharge data. We were able to tap into discharge data from our emergency room at JFK and our hospital. We were able to get discharge data dumped to us in a spreadsheet format from another computer system. And our practice manager dutifully went through and sifted through all this and plucked out those patients that were ours. They didn't just send us our patients, they sent us all, 300-400 patients that were seen in the ER for that prior day. And we had to pluck through and find the 10 or 20 or however many it was patients of ours that were in there. We also started on our hospital service, had our residents put brief discharge summaries in the patient's electronic record. Our electronic record was used in our office. We don't have an electronic record in our hospital. But on discharge, the thought was to have a very brief discharge summary. Patient came in, had chest pain, ruled out for heart attack, had a stress test that was negative, sent home. Brief, to the point, Twitter version of their hospital stay. The idea being that if we were going to have our nurses care coordinate for the patient, call them back after their hospital stay, that they should at least know what was going on, because I'm sure we all know patients, you say, oh, gee, you were in the hospital, what were you there for? I don't know, I had some kind of infection, they did a bunch of tests, and they sent me home, and no idea what happened. So this brief discharge summary was helpful in that respect to help close that loop. Okay, so we developed a systematic process. We started documenting things better. We developed a tracking log to keep track of patients, and we got better information for our care coordinators. Things that didn't work was making sure we identified our patients. The identification of patients in these huge logs from the ER, from the hospital, were based on the patient self-identified answer to the question, who's your doctor? So if they said, oh, I go to JFK Family Practice, all was well, we could find them. If they were at their cardiologist's office and the cardiologist sent them in, they might say, oh, Dr. So-and-so sent me in, and they would put that person as their primary. So trying to identify who our patients were was not always possible. Our emergency room uses a different EMR called IBEX, which, of course, doesn't talk to our electronic record. So it was hard to identify patients that were ours. We still weren't getting information from other facilities. We were only getting information from our hospital. Also, getting the residents to do these brief discharge summaries took some coddling and cajoling to get them done quickly. We weren't relying on dictated summaries. Those take much longer. That's a whole other story. But getting them done in a prompt fashion to tie into transitional care management, where that phone call needs to happen in 2 business days. So making sure the residents were on top of that was critical. So in short, the 2014 submission that we did laid the groundwork for transitional care management and doing that episodic care coordination and closing the loop. Up comes 2016. We applied for and were accepted to the CPC Plus program. Track 1, we're also in that time, we were joined our ACO at JFK. And the CPC Plus came about from Dr. Winter. We had applied for the original CPCI program and were not accepted for that. And then CPC Plus came along, and in looking at it, Dr. Winter said, John, a lot of this stuff is in PCMH anyway, so why don't we do this? And, outside I said, yeah, sure, Robin, that sounds great. Inside I was like, oh, gosh, more stuff to do. But in reality, they overlap quite a bit, and thank God they do, because if you're doing one, it's not that big a stretch to do the other. The nice thing about CPC Plus is it came with money. And, it's nice to have good ideas. It's nice to have bold thoughts and radical innovations, but a lot of times you can think outside the box, but having money, having resources can be a huge help. So what we were able to do with our CPC Plus money is we were able to hire a care manager, a long-term care manager, which is something we had never had before. We also hired a quality improvement / data management person to just keep track of all this. We had CPC Plus data, we had ACO data, we had data for PCMH, we had data we had to submit for whatever alphabet soup program was out there that we were involved with. So that was really helpful, and it took some of that burden off of the providers in the practice. What didn't work is some of the data, especially the CPC Plus data, which is claims-based, and our ACO data, which is claims-based, wasn't timely. You were often a few months behind those data. So that doesn't help us in the immediacy. It's more a historical look. So that was one issue that came up with that. But we did have more resources in the end, and that helped us push forward to our 2017 PCMH submission. In this round of standards, a systematic process was the expectation. And if you can read the standards or you're familiar with them, the word proactive is a key word in there, and that we're proactively doing things. So we had our systematic process in place. We kept a full log of patients, and that had to be shown to PCMH to pass this standard. So we were looking at everybody from the newborns that were discharged from the hospital to the elderly patients that were discharged from the hospital back to home. We looked at all our hospital discharges, all our ER discharges that we could identify for episodic care management. So we further refined our process for care management. We started getting information from our HIE. It was in the form of ADT information and admission discharge transfer, thank you. which did help us identify our patients. You know, so-and-so was discharged from such and such ER. And we found there were a few hospitals in the area that our patients were going to instead of ours. So that was helpful in that respect. What wasn't helpful is that it was just information they had been there. Getting the clinical information from these other hospitals was a big chore and was not easy to do electronically. We still had trouble identifying patients. We still had trouble identifying patients that were going to non-HIE facilities. You know, if our patients were traveling down in Florida over the winter and got admitted to the hospital, we had no idea. We had trouble getting that detailed clinical information from other facilities. Our HIE folks tell us we can do it, and neither Dr. Winter or I have been able to really figure it out. It's a very cumbersome process and not very helpful. Our discharge summaries getting done on time was still a problem. There's a human factor there, and constantly getting on our residents, please finish your discharge summary so our nurses, when they call the patient back, know what's going on. This has been increasingly difficult as our hospital service has gotten increasingly more busy, and we have a lot more patients on it. We're probably averaging 10 to 12 patients a day, medical patients a day on our service, and sometimes getting up to 15 to 20. So that's a very difficult task, in addition to all the other hospital service things that have to happen. We're currently working on increasing our transitional care management coding and working on the process for that, getting the nurses that do our episodic care management more involved in medication reconciliation and making sure that our patients are taking the medicines they're supposed to on discharge, that we know what medicines they're taking. Perhaps they got medicines from the emergency room, and we want to know what those are. And we want to improve our episodic care coordination that way. Okay. So moving on to risk stratification, you know, who are the people that need a little more help? As Josh said, 80% of the costs are from 20% of the people. So, you know, this is something that we struggled with the first couple of go-arounds with patient-centered medical home. Those standards asked us to identify important conditions and things that might be high risk, but it really didn't risk stratify our whole population. And didn't really say, who's your, you know, sort your patients into categories. The Robert Wood Johnson grant that we did, we tried to do that and it really didn't work. We tried to stratify a few different patient populations. It really didn't work out. As a side note, on the plus side though, we did get diabetes group visits started with that. So that was a really good thing for our practice, but nothing to do with risk management. So we joined our ACO, and the ACO said, well, here's your high-risk patients in the ACO based on HCC data, which again, claims-based lags behind. But you know, at least we can say in our ACO, who's our high-risk patients, who should we be focusing on? There were supposedly care managers in the ACO, but they really weren't helpful for us. They had their focus elsewhere. So we didn't get much help from them. And the ACO was a small percent of our population. We have an active population that runs around 10,000. Our ACO population was 800, 850. So, and the high-risk population out of that. So we're looking at less than 1% of our population and ignoring, you know, all the rest of our population that wasn't in the ACO. So, didn't get much boost from the ACO as far as risk stratification goes. In our last go around with PCMH, they kind of hinted at a risk stratification process. It was more of a process than had been in prior updates. That you had to, let's see, I'll read here. The practice establishes a systematic process and criteria for identifying patients who may benefit from care management. Process includes consideration of the following: One, behavioral health conditions. For that, well, let me read through again. Number 2, high cost, high utilization. 3, poorly controlled or complex conditions. 4, social determinants of health. 5, referrals by outside organizations. The issue with this is, to meet this requirement, you had to be able to run a report out of your EMR. You had this, for behavioral health, you had to say, well, how many of your patients are meeting your criteria? And our consultant at the time said, well, you know, how about how many people have had a psych hospitalization in the past year? I don't know. I can't search that in my EMR. The one thing, what we finally came up with is we looked to see how many, we could tell if people were on psychiatric medications. So, and because we had one care manager, we had to limit our population. So we came up with people that were on 5 or more psychiatric medications, which, yes, believe it or not, we have patients with that number of psych meds. So that was our criteria there. High cost, high utilization. We really didn't have any idea about our high utilizers in the hospital or the emergency room. That was, again, something we were just kind of getting started with our logs and so on, and we weren't keeping systematic track of that. And again, I couldn't run a report from our EMR that said what %. So we came up with how many people had 20 or more office visits in the past year. That was our high utilizers. Poorly controlled conditions, that was a little easier. Diabetics, A1C over 12, that's easy. Our EMR can run that report. Social determinants of health, again, very difficult to run out of our EMR. What we came up with were people that were unemployed, uninsured, and lived in a certain zip code. Again, a rough and dirty segment of the population, or to rough and dirty way to call out that segment of the population. What was really helpful was the outside organizations, our ACO, gave us data, and we had our ACO risk stratification data. That's what we ended up basing most of our population on. And we set the barriers on, or the limits on the other population sufficiently small, so our care manager had 120 or so patients to manage because she was only one person. So again, we divided people into these 5 groups, selected out what we thought might, according to PCMH standards, were high-risk people out of those groups. We actually had a care manager that we were able to hire with our CPC Plus money. We started using our data to identify people, and we were able to flag 109 patients as high-risk patients by PCMH standards. So we were moving towards stratification, although you could easily argue that, well, gee, you might have high-risk patients that don't fit any of these PCMH categories. So we weren't identifying everybody in that high-risk category. So we didn't stratify our whole population. It was misaligned with the CPC Plus goal of risk stratifying your entire population. 98% of our patients were not assigned a risk score, or assigned a risk score of 1, default to 1 for CPC Plus standards. The only ones that were identified as high risk were those high risk patients. We had no idea who was in the middle ground and where they were. And we also really weren't tracking any outcomes data on that. That was a little bit beyond what we were capable of at the time. All right, so where we are right now with CPC Plus, moving into year 2, we've just developed, and by next month, we hope to implement and get a process in place of using a weighted scoring system based on the St. Bernard's Clopton clinical risk stratification tool, which, if anybody's interested in it, we have copies. What it basically does is it looks at different factors like utilization, age, medical diagnosis, behavioral mental health diagnoses, and socioeconomic factors, and gives you a weighted score. You get so many points for this, so many points for that, and gives you a number score at the end. And depending what score you are, says you can then set your own limits for your category 1, 2, 3, 4, 5, whatever number you go up to. So we have copies of that. We added other diagnoses to that. It wasn't too hard to do with our system based on ICD-10 codes for different diagnoses. Age was straightforward. For utilization, we were able to search our EMR for those phone follow-up notes for hospital discharges and ER follow-up phone notes. So we were able to use that as a marker for somebody that was in the ER a lot, was being admitted to the hospital a lot. Socioeconomic factors, again, was very difficult. We ended up choosing if patient was uninsured or not as a factor that we could identify readily on all of our patients. So this became a much more data-driven process, and it really looks at our entire population. The next steps we have to figure out is who's going to get care managed, how we're going to implement this process, how we're going to keep it up to date, because this report dumps into a big spreadsheet. The problem is the data has to get from the spreadsheet into our electronic chart. Our electronic record does not risk stratify our population for us. We have to run a report from that data and then feed the data back in. So that's a big challenge that we have to overcome in the near future. And then putting it into practice and figuring out, does it really help? Is it changing outcomes? Are we bending the cost curve? I know we get data from CPC Plus on that, but again, that lags behind a little bit. So it'll be interesting to see what outcomes come from this. And it will also be interesting to see if we get more resources from Horizon or from Hackensack Meridian, which you may know we just partnered with. We're going to be meeting with their population health people in May, and maybe we can parlay our partnership with Hackensack Meridian into some more resources and help and doing this population management. So that was our journey. That's what we did, our struggles, our victories. For future directions, we'll bring Josh back up to go over where PCMH is going in the future.
Thank you, Dr. Metz and Dr. Winter. So I think with many of the practices that the New Jersey Academy of Family Physicians is working with across the state, many of them have started out as a PCMH, and they've gone through several iterations and are now part of advanced alternative payment models like CPC Plus, and even on top of that, maybe an MSSP ACO, and even some folks entering into some commercial value-based care programs. The reason we chose to give this talk with JFK Family Medicine is because we wanted to highlight the fact that transformation does not occur overnight. You can see that JFK has gone through many iterations of the PCMH, and they've really changed and looked at their processes on an ongoing basis. And that's really been very essential for the practice as they move forwards and now start to look at some of the outcomes with the feedback reports that they're getting from the payers, as Dr. Metz said, to see if they truly are impacting some of the outcomes that we want to impact. So a couple things I wanted to highlight again that come out of the new version of NCQA's PCMH redesign. There's more of an emphasis on continuous improvement. By reviewing your progress more often, you keep performance improvement at the top of the list of your priorities, and focusing on intent of the PCMH criteria to achieve outcomes. And you clearly see that as an example with JFK Family Medicine. Additionally, the NCQA PCMH model, for some, was a very rigid model, and practices were forced to kind of perform one way in order to get recognized. There's not a one-size-fits-all to this value-based care journey. There may be best practices, but there's certainly practice variation. The key is the practice takes the path to recognition that suits their strengths and their goals. And you see that kind of reflected in the new PCMH model. And lastly, we discussed some of the challenges that the practice had with the risk stratification model based on care management as defined by NCQA. So in the NCQA process, the practice was able to identify their high-risk patients, but really, what did risk stratification look like for the rest of their population, and how did all of that work? So those are some of the key takeaways that I wanted to share with you regarding the new PCMH design. And I just wanted to illustrate an example of flexibility and how it may help the practice in the future if they choose to continue with their NCQA PCMH recognition. So we saw the practice kind of risk stratify their patients and identify patients for care management through that process, and they identified 109 patients. It was a very, very, very rigid process. There was not a lot of flexibility, and the practice had a lot of trouble integrating that into their CPC Plus model. I just wanted to highlight this as an example. For practices wishing to continue with the NCQA PCMH model, it does fit into the current value-based care landscape. So now it says applies a comprehensive risk stratification process for the entire patient panel in order to identify and direct resources appropriately. And so that's really what we have, what Dr. Metz highlighted at the end. He's discussed a comprehensive risk stratification process that now covers the entire population, which wasn't something that was robustly done in previous versions of the PCMH. This is Dr. Metz's slide. One person, we're too busy, and then the other person pushing no thanks. So this is just a reiteration of our goals and objectives for today's learning session. I'm happy to answer any questions. Dr. Metz is happy to answer any questions. Dr. Winter's happy to answer any questions regarding their ongoing journey as a PCMH, and you can see how the practice has kind of continued to plow through many of the healthcare landscape challenges that we face.
Anybody have questions? Raise your hand.
Hi, I'm wondering if you could speak to one of the things, I work with New York City Health and Hospitals, and one of the things that our primary care practices have struggled with in PCMH is balancing access with continuity and the making sure there's access for those care transitions, balancing that access with improved continuity, maintaining that PCP continuity, and maintaining access for your other patients as well. So I'm wondering if you had any growing pains or struggles with providing access for those care transition patients as you started keeping more robust track of them, and if there are any lessons learned for some ways that you had to deal with that.
I can chime in on one thing if you want.
Yeah. Or you can go first. Yes. Continuity has been a struggle for us also. Certainly at the provider level, our continuity is not that great. It's 33%, which is not unusual for residency programs because we're all basically part-time in the office. So that's one of the issues for that. We do block out a certain number of appointments for emergencies the next day. So we have enough appointments generally blocked out to handle those people that need same-day appointments. And so the transformation of care patients are fit into those slots. To do that, however, we do suffer some continuity. Our team, we are divided up into 4 teams, and our team continuity is in the 70% range, which is not too bad. So we're able to keep team continuity, but not individual continuity. And the follow-up transformation care continuity has been a lower priority for us, as opposed to getting the person in to do the transformation of care.
If I could just weigh in on that as well. Like Dr. Winter mentioned, I think we found other practices to use team continuity as their definition for continuity within a practice, but I think it's important that the patient is aware of who is on that team. They may not be seeing their PCP, but is an introduction to that whole care team a necessary part of that continuity process. I think that's rather important.
One last thing. Dr. Winter mentioned we set aside same-day appointments. We also have another subset of appointments that we set aside that we try to keep open for about a week. We call them our red appointments. And those are the appointments where, for hospital follow-up or ER follow-up, where you don't need to see them that day, but you need to see them in the next few days. So again, it's a pseudo open access kind of model, and just having those appointments blocked for those, for that week ahead of time to fill in for those more emergent slots than the routine follow-up appointments.
Ashish Atreja, Mount Sinai. Have you started using telemedicine to increase access? Because I know it's now approved for New Jersey.
No. No, we haven't. We're hoping with Hackensack Meridian. I hear they're interested in that, and the doctor will call you now kind of approach to visits, and doing some of that chronic care management on a telemedicine basis. I don't know on the digital divide part. We know a lot of our patients don't have access to to Skyping and that kind of thing, or don't know how to use it. There's also the language barrier issue, depending on what languages our patients speak. So that's another issue. But it is something that I know we need to look at, and a whole different way of doing it. And of course, there's the reimbursement question. Are we going to? Yeah, it's nice to do. Are we going to get paid for it? I already make a lot of phone calls to my patients, where I spend a lot of time on the phone with them. But doing that visit on the phone is something that we'll look into. There was, when we got our portal, which was 6-7 years ago. Yeah. There was the idea of having a virtual visit on our portal. It never really took off. Very few patients use it. And I don't know if that's on the patient side or that the product isn't very user-friendly. Be that as it may, the whole virtual visit thing never really took off. So that really hasn't happened. But the telemedicine is much more a real-time kind of thing than an email exchange with symptoms.
I'll just help answer, actually. So they did pass a law last year. Governor Christie passed a law expanding telemedicine in New Jersey, expanding reimbursement, but they haven't put out regs for that yet. So coming.
That was in the back.
Sorry, Edna. Far away here.
Hi. Have you done any work in terms of looking at the roles within your facility? I know I heard you say that you've added a care coordinator to your team and your data analysts, but what about in terms of your medical assistants, your LPNs, your RNs? How have you re-engineered their roles to better be able to meet the needs of the PMCA?
That's been an ongoing process. Through it, the care manager we had added to the practice over the period of this time, actually during the Robert Wood Johnson grant, we trained our MAs to give injections, which they hadn't been doing before, so we upgraded what they were doing. And the nurses doing the call and following up for patients that were doing the short-term interim transformation, care transformation, if you had been in the ER or in the hospital, training our nurses to do that and follow up. So that was also another change, and over time we introduced many more standardized orders for certain kinds of tests to be done. So we have been doing that as part of the ongoing process. That has taken varying amounts of acceptability by different members of our staff in doing those different things. But ongoing training has been an integral part of this whole process during the entire time.
So do you do pre-visits with, preparing the patient before they come to the visit, any of those types of
The pre-visits are divided now between a subset, mostly our ACO patients, where our MAs or nurses will do the pre-visit planning for that, pretty much along the ACO quality measures. And the remainder of our patient population, the providers are doing the pre-visit planning. So that was another teaching and training, was to have the nursing and MA staff do some of the pre-visit planning.
And I guess my last question is around the residents. Are they pulled to the hospital as their first priority, or are they pulled to are they kept in your office to provide the care?
The residents have fixed schedules that put them in the office for a set of office hours. So when they're in the office, they're in the office. They're not pulled back out into the hospital.
One other thing, if I could add, with the, I think with the Robert Wood Johnson grant, we trained our MAs and nurses in doing medication reconciliation for when the patients come into practice. Before, that was supposedly done by the providers and wasn't a very rigid process. So we moved that over to the nurses and MAs with backup from us and those patients with medication lists this long, or where there was some kind of question. But that was also something to generate more of a team process to taking care of the patient. And again, that's something we're working on constantly. It's, they're pushing the cart with the square wheels type thing. Hey, you can do this better. Oh no, we're too busy. We can't change. And every day it does feel like that. It's fixing the car while it's running down the road. It's not easy to do, but we've been able to plug through and work along, and I'm sure there's more work to come.
I could just chime in there. So for the purposes of time, we chose to focus just on care coordination and risk stratification. We certainly know that there's staff roles and responsibilities that come with almost every function within the PCMH. The practice over time has robustly changed and developed their roles and responsibilities grid over time, and that was a requirement of the PCMH. And so just to go back and reiterate, that infrastructure was kind of something that Dr. Winter and Dr. Metz have reiterated to me as their coach, is that foundation work in the PCMH has led them to start to be successful in the value-based programs that they're in now. So the PCMH really laid the groundwork, and now they're up and running. But I know that the roles and responsibilities grid and descriptions have changed certainly over time as PCMH has changed, and also as they've entered into advanced alternative payment models.
Give me a second.
You're gonna get your steps in, aren't you, Title?
Exactly. This is a health conference after all.
Thank you very much. My name is Sadafuni. I'm working with 3 primary practices. I have a question that we have started a new program as a chronic care management services for high-risk patients above 65 with 2 or more chronic diseases for more than a year. Can we train our medical assistants to do this service, or do we need to hire the care coordinators for this service? Because it's not so much paid or it's so much successful that we hire new staff for all this purpose. So is it eligible that medical assistants can do this phone call, enter the data, encode them, and bill them? Or do we hire a new staff like care coordinators or case managers for providing the service?
That's a good question. Part of our practice transformation that we did was trying to get everyone to work up to the limits of their licensing. Dr. Winter's probably a little more familiar with what an MA can and can't do than I am. So MAs could certainly do some things. They could certainly call to follow up on labs, make sure patients are keeping appointments, that they got referrals, that kind of thing. The care manager, a little bit more clinical oriented, developing care plans with patients, going over care plans with patients, providing somewhat of a social worker role and connecting them with resources, although MAs can also do that. I don't know, add to that, Robin?
My understanding of the regulations in New Jersey is that MAs can do the phone calls. So there are practices that will use MAs to do the follow-up phone call from the hospitalization and see how the patient's doing. But that actual care planning is at a higher license level, either an LPN or an RN. So that it's, at least my understanding, MAs cannot do what would be technically the care plan that you would be putting in with like CPC Plus or more advanced care planning. So that would be a higher level LPN RN function to do.
If I could just chime in there as a kind of a coach working with practices across a variety of CMS programs, that is probably one of the most commonly asked questions, and I think it's worthy of a follow-up. So I think that one of us in this room will follow up with the appropriate answer as to how that works in the state of New Jersey. I think it's a little bit of an unclear answer to me at this point, but I think Dr. Winter probably gave you his best educated guess for right now that some of those care planning functions really do need to be done by someone with a higher license level.
Can I add, just to answer the question directly, yes, an MA can do a lot of the work as part of the chronic care management program. And as the doctor says, to have the care plan initiated, there is an additional code that you could use as well. It's usually done by the doctor or the nurse practitioner in terms of doing the plan of care. There's a code for that in addition to the care CCM code. And so, and it's about the time. How much time is being utilized by the clinicians to do that care? 20 minutes a month, and you're eligible for that. So the idea is not so much to have a bigger team, is to have a team that can actually record their work with the patient, their use of the chart. Even looking at the chart is counted. Reviewing the meds, reviewing med reconciliation, so forth. That's all also included. If I could talk some more about directly with you about that.